growing up in South Africa, I saw as a young kid a huge population that when they became mentally ill, got no treatment, landed up on the streets. So from an early age, I always thought, boy, why can we not take care of those who do have a mental illness? And then during my medical school, when I started to do community work, it became more and more evident to me just how neglected, mental health and mental illness was in the community and also in the hospitals. I'm talking about now the late 70s, early 80s. So that's what piqued my interest. And then when I came to America, in some ways, we were faced with the same situation, that mental illness was treated differently to if you had a primary care disease. So when I decided what should be my specialty, and I always believed in that biopsychosocial aspects of mental health and mental illness, it was a wonderful opportunity for me to go and do my psychiatry training. It was a elderly lady who had attempted suicide, and she had attempted suicide with her crochet needle, which is not a very sharp needle, and she had become progressively depressed, and no one had really paid attention to her because she was living alone. And fortunately, it was discovered early and came into the hospital. And when I looked at that and looked at her and saw the treatment that she had gotten in the past or not gotten, it really reinforced for me, the issue of that this is where I'd like to devote my future profession, is taking care of those who in some ways are the most vulnerable in our healthcare delivery system. The American Psychiatric Association is very clear that we're a team, and we need to work together as a team for the patient that we serve. And I think the American Psychiatric Association, myself now as their new CEO, is clearly moving towards how do we bring in all the groups that deal with our patients and say, let's sit around the table and work out the best possible care and continuum of care, starting with prevention, going to early intervention, going to treatment, and then keeping them in the recovery of their treatment, so that if they do relapse, we catch it early, and if they move on to being healthy mentally and physically, that they don't have to be that much part of the system. So I think that there's a great opportunity, particularly through this conference and the Kennedy Forum, to bring together all the groups, and APA stands ready, being the psychiatric and psychiatrist leading organization, to be part of that partnership. I think that we have to all remember that we are patient-centered, and we all have our training and expertise in particular areas. A psychiatrist, as you know, who have gone through at least 8, 9, 10, 11 years of training to become a psychiatrist, both from psychopharmacology to the neuroscience now, that is becoming the future of psychiatry. But we also have the diagnosis of psychiatry, and that's what DSM is about. That's what all us as practitioners use as a way of talking to one another. And I think it gives us as APA and as psychiatrists to be part of a team where we're able to bring our expertise, both from psychotherapy to psychopharmacology, and to ensure that it's the total care of the patient. Parity, and I think that's what we're all here to do as we wait for the final rule to come out, that we are here to ensure that every one of our patients gets the same care, the same opportunity to receive the care that they need. And I think that is the true focus of what we now need to do. And here on the 50th anniversary of President Kennedy's signing of the Community Mental Health Act, that this is one more way that we can ensure that we essentially become part of the healthcare delivery system, both at the federal level and at the state level.